Right. Whenever you're ready.
Okay. So, obviously we're going to be talking about kidney stone disease today, and then just going through a brief rundown of the workup and talk about different treatment options that are available. Let's see. Okay. So, I'm part of the advanced urology group. We're sort of a large urology group in the area with over 10 locations and 40 providers. Dr. Patel, who's on this meeting, is also part of that group. And we serve the sort of greater Atlanta area. A lot of our providers are fellowship trained, and we treat a wide variety of urology issues. I've been specifically here about 3 years now, and while I do most of the robotics, my secondary interests are definitely kidney stones and urologic reconstruction. And since most of our locations have a surgery center attached, it's quite easy for patients to be seen same day, and we can offer rapid treatment for a lot of the diseases that we do. And one of the main things that we see all the time, is a kidney stone patient with acute renal colic. And so we can get them in on the same day, ultrasound them if needed, and even stent or treat the stone within 24 hours. So, this is sort of a good segue into our topic today, because as urologists, even though we love to operate and do these kinds of cases, kidney stones do represent a significant burden on medical resources. So it's important to be able to minimize patient factors and risks and reduce the frequency of these emergencies, if not prevent them altogether. And so the objective of the talk today is really to just discuss the most common types of stones, the etiology and risk factors for these stones, to describe the basic workup in terms of management, when to refer to us, and then to just discuss preventative strategies for future episodes. So, kidney stones, how do they form? Normally, the theory is that soluble material supersaturates in the urine, and then it begins the process of crystal formation. And then these crystals can become anchored at either damaged epithelial cells or at the membranes. And when it becomes an anchor, the nucleus is created so that crystallization on top of this nidus can occur at lower chemical pressures than required for the actual formation. So other things that can act as nucleating centers can be like epithelial cells, urinary casts, even blood cells, or other, more soluble crystals in the urine. And then sometimes during procedures that we do, you can see this sort of calcification on the papilla. These are called Randall's plaques, which are sites of further stone deposition. And so a lot of the stone management strategies that we have for prevention deal with reducing the saturation of these materials. And then the easiest strategy is to dilute the urine with increased volume of urine. And so here's just a picture of some of these Randall's plaques. You can see it's sort of calcification on the lining of the actual kidney. And this is more embedded on the inner part of the kidney. And so what are the fine or the general characteristics of kidney stones? Most of them are radio-opaque, meaning that you can see them on a CT or X-ray. The most common kind of stone composition is a calcium-based stone. Those are calcium oxalate or monohydrate and dihydrate stones. And the biggest factor, which is specifically in the South, is dehydration, because that leads to decreased urinary volume, and that creates a situation where you can have supersaturation of some of these dissolvable minerals. And the most common abnormality that is seen in stone formers is the hypercalciuria. So, there's a fine line between stone forming salts, such as calcium oxalate, and inhibitors such as citrate and magnesium. And when balance is tipped one way or the other, the stone formation can occur. So besides just urine volume, there are many other etiologies at play that can cause kidney stones. Mainly genetic. Dietary factors can also be important. Anatomical abnormalities can lead to urine stasis and again cause supersaturation or aggregation of crystals. The urine composition we'll talk more about as we talk about the metabolic workup, but diet plays a very important role, and it's usually the first step in reducing risk factors for patients. Namely, if you can reduce renal acid loads, which causes increased acid, which decreases urinary citrate. Things such as eggs and cheese tend to have a high renal acid load. Fruits and vegetables actually decrease the renal acid load and already have a lot of citrate in it to prevent kidney stone formation. Other dietary factors such as sodium, oxalate, even carbonated drinks through the use of phosphoric acid can increase risk of kidney stones. Other disease states such as diabetes or gout, acidosis, cystinuria, or even hyperparathyroidism can cause increased predisposition to kidney stones. And then metabolic acid or acidosis is an important risk factor too, because it increases urinary calcium and phosphate, and it decreases citrate, which is the preventer we talked about. In terms of UTI, the UTI reduces citrate in the urine, and normally what happens, or why that happens, is that urease producing bacteria split the urea into ammonia and bicarb. So this leads to an alkaline urine and increases the risk of forming stones that form in such urine, such as struvite kind of stones. And so typically these urease splitting organisms are Proteus, Klebsiella, or Serratia, or like Enterobacter or Morganella. So as an aside, if you have a patient with recurrent urinary tract symptoms or recurrent urinary tract infections, and they have these organisms, it's important to get some anatomical imaging to rule out any presence of kidney stones, because they'll just harbor in those stones and continue to form these kinds of infections. And so, we talked about genetic factors. The main thing really to take away from this slide is that many different genetic factors or abnormalities lead to the same sort of factor or same sort of urine abnormality, which is hypercalciuria. And in the reason why talking about kidney stones is important is that about 3% prevalence of all adults have kidney stones at this time, and about 12% of the population will be affected in their lifetime. Usually men are at a greater risk of forming kidney stones on a ratio of 3 to 1. And then it tends to be a younger kind of population, usually ages 20 to 49. And then the younger you are, the obvious increased chance of the stones coming back in the future. And these rates can be up to 50%, as you see here. After a first stone episode, it can be 14% at 1 year, 35% at 5 years, and then 50% in the next 10 years that you're likely to suffer from another kidney stone episode. And unfortunately, the South and Southwest actually have the highest incidence of kidney stones, likely from the dehydration and also just a very hot climate. So the main kind of kidney stone we talked about is a calcium-based stone. Again, the most common cause is dehydration. It's radio-opaque. There's really two main subtypes, the monohydrate and the dihydrate. The difference is really crystal shape. So if you're looking at a urine specimen, you see like ovals or dumbbells, you can tell it's a calcium oxalate monohydrate type of stone or crystals present. The dihydrate tends to form octahedrons or envelopes. And the second most common type of kidney stone is uric acid. Again, the most common cause is dehydration, but this forms in an acidic urine in patients who have hyperuricemia or increased supersaturation of uric acid. The one difference between the calcium-based stones is that these are radiolucent, meaning that you cannot see them on KUB or X-ray, and their crystal shapes tend to be parallelograms. And then we talked about the urease-producing organisms such as Proteus and other things that cause these struvite stones. These tend to be larger. You sort of think of the staghorn kind of stones. They also form in alkaline urine. They're visible on X-ray, visible on CT scan, and they sort of look like coffin lids. And here's some pictures of what these stones look like as we discussed. And again, these things are really, if you see it on a urine specimen, normally when you do analysis of stones, this is not how you're going to be doing the analysis. The way that it's done is when it's collected, the best thing is to do is to send it for the chemical analysis, and it's done via X-ray diffraction and then infrared spectroscopy. So this allows you to detect multiple different minerals within one stone. And the way it's done is that it's crushed into a powder, the beam passes to the powder, and then the different molecular bonds of the mineral content of the stone will absorb a different portion of the radiation, and you have a unique spectra. So it tells you the different chemical constituents of the stone. And for the vast majority, the kidney stones are asymptomatic. It's really when they drop into the ureter that will cause the classic renal colic, which is the acute obstruction, dilatation of the ureter, and spasm. So you have this waxing and waning flank pain. Because the ureter is sort of the rate limiting step, meaning that it's the tube which has the hardest part of passing the kidney stone, and it's dependent on the size of ureter. So obviously the younger you are, the smaller the size it is. It's the usual problematic stones tend to be less than 1 centimeter. And patients can have these stones without knowledge of it, because if they don't have any obstruction, you don't have the pain. The three main areas where you tend to have kidney stones get stuck is at the UPJ, so this is right at the entrance of the renal pelvis into the ureter. The larger stones tend to get stuck here because, again, if it's able to make it in the ureter, it tends to have a smaller size. Mid-ureter, where the ureter crosses over the common iliac vessels or the iliac vessels, that's another point where it can get stuck. And then lastly, they can get stuck at the UVJ also, or the entrance into the bladder. That's usually what you end up seeing, is that you have this last push of pain, discomfort, and then after that patient has passed the stone into the bladder and they no longer have any symptoms. And some of the symptoms that you can have is, hematuria, nausea, vomiting, flank pain. As the stone is getting closer and closer to the entrance into the bladder or the exit of the ureter, you tend to have some dysuria, urgency, and frequency. So you have these lower urinary tract symptoms, which sometimes can be hard to distinguish between a urinary infection or just a passage of stone down below. So the main thing that usually presents the patient to the hospital or to any office is this acute onset of flank pain, and it can radiate from the flank down to the groin, scrotum, or genital region. It can wax and wane, as we talked about. It can be accompanied with blood in the urine, nausea, vomiting, other systemic symptoms. A lot of times people think, they just can't get comfortable. They're constantly moving around. Somebody, usually mentions that it's worse than childbirth or the worst kind of pain that they've had. So it's important to, aside from this, to think about other factors to assess their acuity. Main thing you want to rule out is an infection. Did they have any fevers, chills? Did they have any blood in their urine? Did they have any history of kidney stones? And if they did they pass those on their own, or did they need a procedure for every stone that they had? Do they have any history of urine infections in the past, or any history of renal failure? If they have a solitary or transplanted kidney, that's really more of an urgent issue and needs to be addressed immediately. And also their occupation. And lastly, when did they last eat, in the case that they may need an intervention. So, most of the workup is the basic kind of workup that you end up getting done in the emergency room or at the office anyway. It's a basic blood test to check for white count, to check your creatinine, to check kidney function. And then we can check a urinalysis, urine culture. You may even see the crystals that we mentioned before. You may see blood cells or other things. But the biggest thing that really is helpful to determine the size and the location of the stone is a CT abdomen pelvis without contrast. And nowadays we can do it with a stone protocol so that the amount of dose of radiation is pretty much similar to like an X-ray. And ultrasounds are useful in patients who have a history of kidney stones. So it's a good screening test to see if there's any presence of hydronephrosis or if there's any other abnormalities up in the kidney. But in a patient who has more of the other acuity factors that we talked about, it's better to just get the CT in the first place. And treatment-wise, most of these patients can be managed as an outpatient. The number one thing, like we talked about, is dehydration being the issue. The biggest thing I tell patients is to drink as much as they can. I really want their urine to look basically like water. And when they do have, or when they're undergoing an episode of kidney stone or acute colic, they should be straining their urine to catch the stone for analysis, because even though they have a history of one type of stone, there's a possibility that different dietary factors have now created a propensity to form a different type of kidney stone. The other main thing is medical expulsive therapy. So that's pain medication, alpha blockers such as Flomax, and the other important part is to, while taking this medications, is to make sure that they're not only straining urine, but they also are being assessed frequently to make sure that they're passing the stone appropriately. And most stones that are fairly small, so less than 5 to 6 millimeters, should be able to pass within 2 to 4 weeks, given the size and location of them. If they're not able to pass the stone within that time frame, then that usually progresses to more of a treatment episode, not necessarily just continuing with the expulsive therapy. But if there's any instability to the patient, then that requires an intervention. And we talked about the different reasons that the patient would need an intervention. So if they've had an obstruction longer than 4 weeks, and the reason this 4 weeks is sort of the magical number is that permanent renal damage is thought to occur after about a month. And this is from studies that were done in animals where the ureters were tied off and then the kidney function was monitored. If a patient has stones on both sides, that's another emergency. Or if a stone is in a solitary kidney or like a transplanted kidney we talked about. Any concern for an infection or any concern for rising creatinine is an indication to perform some urgent decompression. Or if patient just overall is not able to tolerate anything by mouth, or they're having issues controlling their pain with just oral medications. And if there's any doubt, you can just call one of us. We can see the patient very quickly. We can get them treated as soon as possible. And so, why this occurs, the stone is not the problem. The problem is at the blockage. So the kidney cannot eliminate the urine that it makes into the bladder. And so if there is any instability, or if the patient requires a treatment, the next step would be decompression of the kidney, either via an indwelling ureteral stent or an external nephrostomy tube. And obviously, if there's a concern for an infection, the stent or the nephrostomy tube will decompress that infected urine, it would allow the antibiotics to work, and then the stone can be addressed at a later date as needed. And then the stone is, not treated until the patient sort of stabilized and get past this acute episode. And in terms of the medical expulsive therapy that we talked about before, it really depends on the location of the stone and the size of the stone. So again, you can see over here, the smaller stones tend to be, above 70% passage and within a week or two. But as soon as it's getting closer and closer to that 1 centimeter mark, that rate of passage drops and the length of time increases. So, normally if it's a proximal stone that's like 9, 8, or a centimeter in size, that's going to be something that's probably going to require treatment. And so it's important to counsel patients or give them an expected reality of their stone or of their next couple of weeks. And so if you have a situation where a patient does require treatment, for example, like this, a large proximal stone here, or situations where a stone has been stuck at the exit into the bladder or entrance into the bladder for a long time, or you have this continued dilation or maybe even some stranding around the kidney for a possibility of infection, what is the step? So for these sort of smaller stones that are in the ureter, the first and probably the easiest step would be a uteroscopy. This is an example of what tends to occur. So we have a small camera that goes up the ureter, and we identify the stone, we break it up with the laser fiber, and then we basket these pieces out. And then at the end, most likely leave a stent if the stone has been there for a while and has been causing either swelling or inflammation of the surrounding area. Now, if the stone is quite large or up in the kidney, then the other alternative would be what's known as wall or extracorporeal shockwave lithotripsy. The advantage of this is that it's not invasive, but the disadvantage is that the stones are not removed. So the basis of shockwave is to fracture the stones using a focused wave into smaller fragments, and then the patient will then pass these fragments spontaneously. The shockwave is generated inside the lithotripter and then it's focused on an external point. And then to ensure the correct position, you would usually have fluoroscopic guidance at the time. So, we talked about that the benefit is that it doesn't require instrumentation, but it can't be used in all locations of where the stone may be. So it's really best used up in the kidney if there's a stone in the renal pelvis. Another disadvantage is that you can potentially have some long-term kidney complications, possible increased risk of diabetes or hypertension. And then the one other complication that can occur is you can shock these stones into such small pieces that they all then get dropped into the ureter and you create sort of a stony street of passage, which can't be passed. And so if the stone is so big that even the shockwave would not be effective, or if it's quite hard, then the next step would be what's known as a percutaneous nephrolithotomy. And this allows for insertion of a larger diameter rigid camera directly into the renal pelvis. This goes through the kidney and down into the renal pelvis. And then through the scope of the sheath, you can use a suction and more potent energy sources such as ultrasound and pneumatic lithotripsy to apply pressure and break up the stone. And then this allows for larger clearance of the amount of stone in a much shorter time. The primary appeal of PCNL is that it has a superior stone-free rate when compared to S-wall uteroscopy in the stones that are higher up, especially in stones that are large and in complex different calyces. but it does carry a higher risk profile because you're establishing a tract through the kidney. And so there's a higher risk of bleeding, and patients may need transfusion, about 5 to 7%, higher risk of embolization after this procedure, about 0.5%. And then depending on how high your access is into the kidney, because sometimes the pleura sits in between the kidney and the back, you can have chest complications, such as hydrothorax or hemothorax or even pneumothorax, and that's about a 1 to 2% chance. So, it's not a surgery that's taken lightly. Now, in a situation where if you have a stone that occupies a large portion of the kidney, like here, or even a major portion that might require multiple access ports to get to, then a slightly more invasive option and probably a better option would be a laparoscopic procedure. As you can see here, this is a robotic pyelolithotomy. So we make an incision into the renal pelvis and you remove this stone in one piece. And then you just close up the pelvis and place a stent to allow it to heal. But because it's a more invasive procedure, there's a little bit of a longer recovery, but it allows you to get rid of all the stone in one procedure to be stone free. So it is a nice option for patients who are good and able to undergo a procedure like this. So in terms of management after you capture the stone, all patients should have their stones undergo chemical analysis, because even though if the chemical analysis of a calcium oxalate, or if the stone shows calcium oxalate, many different metabolic analyses lead to the same result of the calcium oxalate. So it's important to assess and see what the abnormality is. The initial management of preventing kidney stones, as we talked about, it's always dietary changes. It's that hydration. You want the urine to be at least about 2.5 liters. You also want to increase fluids or things that have a high volume of citrate. So adding lemons or lime slices to every cup of water you drink. These are two naturally preventative ways to prevent kidney stones from formation. In terms of the other dietary factors that you can look at is that increased sodium intake usually causes urine sodium to rise, which then further increases your urine calcium. So when looking at your daily sodium intake, that should be about 2,000 milligrams per day or 100 milliequivalents per day. And you tell these to the patients, they sometimes have to do some calculations to figure out what they're doing, but a lot of times they're ingesting things that are secretly laced with sodium without realizing it. So it's important to give them these numbers that they can figure out what they're doing inappropriately or even appropriately. And then oxalate content is an important thing. This is usually found in like nuts, spinach, teas sometimes. So it's important to not be intaking too much of that, because that will bind with calcium to form these kidney stones. Another common misconception is that cutting out calcium completely from your diet will stop kidney stones, but actually the opposite is true. If you have a low calcium intake, then you're also at increased risk of forming kidney stones. So you should really be about 1,000 to 1,200 milligrams per day of your calcium intake. In terms of animal protein, the recommended guideline is about 1 gram of protein per kilogram of body mass per day. And then it's also important to see what kind of vitamins that you're taking. So, vitamin C and D can increase urinary oxalate and calcium respectively, and then again, cause an increased chance of forming kidney stones. The other thing that's important from a patient-to-patient basis is that these inhibitors don't always work equally for everyone. So even if your citrate is sky high, or even if your hydration and urine volume is really high, some people just will form stones. But if the crystals that are formed remain tiny, then usually they travel through the urinary tract and pass out from the body without being noticed. And the inhibitors are important because they will act directly or interact with the crystal, and it will influence the urinary environment to reduce the risk of forming kidney stones. So who should get a metabolic evaluation? All patients who are a high risk, and these are patients who has a large burden of stones, who've formed recurrent stones. These are younger patients. These are patients with uncommon composition, so not your typical calcium oxalate based stone. These are also patients who have a family history, a solitary kidney, or people who work in fields where passing a stone may cause dangerous situations to others, such as like pilots or bus drivers. And it's important to time the metabolic evaluation. So it should be at least a month after any obstruction or stents have been removed or any infection has been resolved. And the initial evaluation should include blood and urine tests. So the serum chemistry looking at uric acid, calcium, and kidney function. If your calcium is elevated, then you also want to order PTH for possible primary hyperparathyroidism. And then as far as the urine test is concerned, it's a 24-hour urine collection. The most common brand is Elitolink. It's quite simple. They send the kit to a patient's house. The patient urinates in it for 24 hours, and then they ship it back out using a label that's already been provided. And then again, these studies should then be repeated 2 to 6 months after starting any intervention, just to make sure that things are looking or moving in the right direction. And so when you do a Litholink, you sort of get a report like this. It has all the factors that can increase or decrease risk of stone formation. It also gives you a 24-hour creatinine to make sure that it was a properly collected sample. So, and it will also look at previous Litholinks that the patient has had to see what the improvement has been, or to see if their diet modifications or other therapeutic interventions have had an effect. In terms of oral medications, the biggest thing on the market right now is citrate bicarbonate. And the whole point of citrate, again, it reduces the kidney stone formation by correcting acidosis. It increases the pH of the urine. So it allows, again, to reduce your risk of forming uric acid stones. The preferred one in use is potassium citrate. Usually I do 15 milliequivalents twice a day, sometimes 3 times a day. But it is important that if you're doing potassium citrate to monitor serum potassium. You can use sodium citrate in people who have kidney disease, but again, you're increasing the sodium load with that. So then you're also increasing the risk of possible stone formation. The second subclass of oral medications, the thiazides, these help increase resorption of calcium. And so thereby decreasing your excretion and correcting the acidosis. They have about a 30% reduction in calcium stones. And in addition with the thiazides, if you have a low sodium diet, it will enhance the hypocalciuric effect too. However, the downside is they can have a declining effect in some forms of hypercalciuria. And then some of these other availables for more specific kinds of stones would be allopurinol, which prevents uric acid stones when uricosiuria is present because it inhibits the anthene oxidase. It will also prevent calcium oxalate stones in the setting where you have normal urine calcium, but increased uric acid. So what's happening there is that uric acid crystals form, and then the calcium oxalate just binds onto that nidus. And the risk of reduction is about 22% reduction in stones if you're on allopurinol for uric acid-based stones. Magnesium itself is a natural stone inhibitor, and it can be used in patients who have hypomagnesiuria, again, which you'll find on the Litholink, and that's something that can potentially be used for patients. And then other specific medications for treatment for like oxalate, cysteine, and matrix stones are pyridoxine, lithostat, and then thiols also. So, these are the most common kinds of urinary abnormalities that we talked about. You can see that potassium citrate usually is what we use to address these problems. So really, when in doubt, that's an easy medication to start. It's pretty well tolerated. There are also over-the-counter supplements that have potassium citrate naturally in it, like liquid IV. There's potassium citrate, just pills you can get. So, I usually tell patients to get those things to help reduce their risk of stone formation. But the biggest takeaway is that, it may take some time repeating studies after interventions, but urine composition will change if the patients are invested and if they're involved in their care. And the risk of future episodes will decrease as a result too. So it's important to continue to monitor not only the formation of the stone, but also the progression of the size too. And this is usually done in addition with just a Litholink and stuff with ultrasounds to confirm and make sure they're not getting in a situation where they may be setting themselves up for failure. To just talk about some of the new technologies that are sort of on the horizon. I came across this where they're now dealing with focused ultrasound. And so one of these experiments are actually from the International Space Station. So astronauts are exposed in space flight. They have increased risk of kidney stone formation. And usually some of the medications that they also use to combat space flights associated like neuroocular syndrome increase the risk of their kidney stone formation. So currently in development, there is a flexible ultrasound system that was tested at the space station to allow researchers to not only detect kidney stones more effectively, but also to manipulate stones in the kidney. So This is a picture from the test itself. So this is an ultrasonic propulsion type of technology. On the left, you can see the image of the stone with the color, or which shows the stone in the color. In the center, there's the image of the stone that has moved after the first push attempt. It's moved about 2 centimeters to the left. And then on the right, you can see in the same kidney after the second push, the stone has moved out of the image plane and then has exited the kidney. So, the utility obviously is far from mainstream, but it may in the future allow for prophylactic passage of kidney stones while avoiding unnecessary trips to the emergency room. And currently, this is called the stone clear technology. It's available in clinical trials, and it'll help clear residual fragments or even small stones. And the way it's done is really 15 minutes in the office setting, done without anesthesia or X-ray radiation. So, something on the horizon for the future, which may be helpful to all. So some just important takeaways. The biggest thing is to optimize dietary factors, optimize hydration, cut out salt, cut out protein, and cut out calcium. You want to do frequent 24-hour urine studies, again, to make sure that patients are doing the appropriate things, that they're also doing what they tell you, and then also that the interventions that you're using are actually working. And then, starting basically with potassium citrate or citrate supplements is always a good first step. If you want, to start treating patients with kidney stones. And then recurrent urinary tract infections, specifically with those ones that we mentioned, the Proteus, Klebsiella, Morganella, Enterobacter, they definitely need some form of anatomical imaging to figure out what's going on. And then the other biggest thing is a patient who is actively passing a kidney stone needs a documented resolution, because what can happen is you can have the presence of silent hydronephrosis. Patients themselves feel like they're completely fine, they've passed the stone, but in fact, the stone is still stuck there. And the reason for that is there's a sort of a pop-off valve mechanism in the kidney, so that if you have a long time pressure, that fornicale rupture occurs, the pressure is relieved, the pain and discomfort go away, but the stone is still stuck in the ureter. And over time, that can cause more scarring, more inflammation, strictures of the ureter, or potentially even detriment in kidney function. And that is it. Any questions?
That was a great presentation, Dr. Patel. Actually, Dr. Tannenbaum does have a question, and I'll read it to you. Do ureters have a muscular layer where medication might lead to dilation?
Yeah, so they have, that's where the thought process of Flomax is, that it leads to dilation of that sort of circumferential muscular layer. But recent retrospective or recent meta-analyses have been done, which show it's really mainly for patients who have very small stones, so like 4 to 5 millimeters or less, and in the distal part of the ureter too.
And then with that, what anatomy actually leads to renal colic?
If it's not kidney stone related, what it can be is like a UPJ obstruction, or anything that prevents the exit of urine at a normal rate. So UPJ tends to be the most common thing, but you can also have a high inserting ureter. So instead, if you imagine it's like a funnel, instead of the funnel mouth being straight down, the actual opening of the ureter is at the top of the funnel. So the urine has to sort of climb up and then go downwards. And so you can have stasis of urine in the renal pelvis, and that itself can cause episodes of renal colic.
But isn't colic a recurrent spasm?
Yeah, so it's a recurrent spasm in the sense that you have pressure buildup in the kidney, and it's causing stretch of the actual kidney fascia, and that's where the pain is coming from. So any situation where you have decreased flow of urine, you're going to have colic potentially.
Wow. Thank you for your time, Dr. Patel. And we are recording this, so anyone who does want to see it can certainly call our office, or anyone that you know of, please tell them to call and we can get the recording to them.
Perfect. Well, thank you everyone for taking the time.
Okay, have a great evening.
You too. Bye now.